topic assigned to me today is anomalies not to be discussed on the ultrasound. Malti, next slide, please. So I'll give a brief introduction, major malformations, anomalies not to be missed, and I'll also give you insights that anomalies that can be missed so that you can counsel your patients accordingly when you land up in these critical situations where the patient keeps you asking what went wrong, so that you are able to counsel them properly. Next slide, please. So as per the Indian study, the prevalence of the malformation is about 6 to 7%, and out of which the congenital heart disease tops the list, followed by the neural tube defect, which is about 5%, and the congenital deafness, which is about 5.6 to 10 per thousand. Next slide, please. So the congenital malformation, as per the WHO data in 2016, about 3 million children were born with the congenital abnormalities. Next slide, please. So an estimated about 240 million newborns die worldwide within 28 days of birth, and congenital disorders cause a further 170,000 deaths of the children. 9 of the 10 children born with the serious congenital disorder are in the low and the middle income group, and that highlights that why it is very, very important to identify the children with the congenital malformations. As neonatal and under 5 mortality rates decline, the congenital disorders are increasingly becoming a larger proportion of the cause of the neonatal and under 5 deaths. And the most common severe congenital disorder, heart defect, NTD, and of course the Down syndrome. Next, please. So this is the recent data by the WHO, and we can see here when the proportion of the infant mortality decreases, the proportion of the children with the congenital malformations is, when infant mortality is less than 5, they account for about 30% of the cases of the infant mortality, less than 5 years. And whereas if the infant mortality is on the higher side, like more than 55, it is about 4%. So the better you grow, the congenital abnormalities will take a larger chunk of the children with the mortality in the under 5 years or the neonates. Next slide, please. And these are the recent data. And the congenital disorders, they can be the prevention of the birth defect is the most common aim of those who are working into the field of the genetic and the fetal diagnosis. And the causes of this, they could be the prenatal exposures like the drug exposures, or it could be chromosomal like Down syndrome or DiGeorge syndrome. It could be even a single gene disorders like the harlequin ichthyosis, or it could be multifactorial. But most of the time, in 40 to 60% of the case, or you can say that in the 50% of the cases, the cause remains unidentified. Next, please. So next slide, please. So fetal structural abnormalities, they are seen in about 2 to 3% of the all pregnancies. And as we all just discussed, that the ultrasound is screening for fetal structural abnormalities. That is an integral part of the routine prenatal care in the well-resourced countries, and of course in our country as well. And the prenatal detection of the structural abnormalities, that provides our expected parents with an early opportunity to obtain the information regarding the condition, including its nature, etiology, prognosis, and the availability of the postnatal or the prenatal therapies, so that the delivery can happen in a tertiary center, like a child with a new fetus with the cardiac abnormalities. We prefer to send them to the center where the cardiac care can be taken, rather than transferring them the postnatally. So identification becomes important in the management. And the mid-trimester anatomical survey typically is performed between the 18 to 22 weeks of the gestation. And this has been the standard of the care for the detection of the abnormalities in many of the developed and the developing countries. Next slide, please. The major professional societies throughout the world, they recommend that all pregnant women should be offered between 18 to 20 weeks. And the second trimester allows for the optimal examination of the anatomy, along with the screening for the soft markers of the aneuploidy, evaluation of the fetal size, and the presence of the structural abnormality. And this is the standard of care. Next, please. So what are the factors which will affect the detection rate? So there has to be a standardized protocol, and this is updated by ESOG in 2022 as well, that there has been a standardized protocol so that we can identify the maximum of the abnormalities. And of course, the detection depends upon the maternal BMI. And the training is, I feel that the training is the most important part of the factors affecting the detection rate. Your equipment should be the new enough, and of course, a pregnant mother should have an access to scan, and that depends upon the healthcare development, the healthcare policies of our country, that all the women should have an access to a scan. Next slide, please. So, in the Lancet stillbirth series, the congenital abnormalities, they are the major contributor of the morbidity and the mortality. And as per this paper, they suggest that the minimum one ultrasound for the fetal anatomical survey should be offered to all pregnant women. Next, please. This is a study by Bhinde et al. In 2018, and we can see here that the risk of the central nervous system abnormality is about 75.85 per 10,000, that is 0.75%, musculoskeletal 0.65%, cardiovascular 0.75, and GIT abnormality, and these are all in the infants or the neonates born after the delivery, that is, these are the abnormalities which were picked up after birth. Next, please. Next, please. Next. So what constitutes an anomaly scan? That is the targeted ultrasound. And when should we do that? 12 weeks, 18 to 20 weeks, or 32 weeks? So probably for us, for our country, 18 to 20 weeks is the most ideal time to do the anatomical survey. Next. In the anomaly scan at 18 to 20 weeks, we do the evaluation of Dr. Krishna Gopal has already highlighted, but just to briefly overview that the examination of the CNS, including the spine, the face, the eyes, the ears, and the intracranial anatomy. Then we move down to, next please. Then we move down to the neck and the chest. And in the chest, the most important structure is the heart, followed by, when we go down, it is the stomach, both the kidneys and the urinary bladder, and followed by the external survey of all the limbs, face. So all these will give us the full anatomical survey of the fetus from top to bottom. Next, please. So now coming to the fetal major malformation, these are the basically I have concentrated those which are more common, and so these will include the central nervous system, the cardiovascular system, the genitourinary system, the GIT, the skeletal system. Next, please. So the neural tube defect among the CNS, they are the commonest CNS malformation, and most are detected on the first trimester scan, and almost all can be detected at a 20-week scan. Sensitivity for open NTD is not 100%, it is about 81%. And this depends upon because many of the lower part of the spine is delayed ossification, and also depending upon the fetal position. So sometimes we do come across, even in the current times also, that the diagnosis of the neural tube defect, particularly the open neural tube defect, is challenging, and it is not in the periphery. Even talking in the central Delhi also, I have realized that the neural tube defect which we feel that should have been 100% detection, but there are challenges because many a times the spine, the fetal position is not favorable, and also the surface of the fetus, of the skin, is not easily visible to the ultrasound machines, because most of the ultrasound machine, they are very good at the internal structures, not good at the outside structures, which will be discussed later on also. Then the ventriculomegaly, agenesis of corpus callosum, which is associated with the developmental delay in about 15 to 20% of the cases. This may not be picked in the first trimester scan, but it should be picked up 20 weeks and beyond. And this is also one of those abnormalities which I feel that we are missing, and we are seeing them many a times. We are seeing them in the third trimester. Next, please. So congenital cardiac abnormality, which are commonest, that is 8 per 1,000 live births. And fetal heart assessment is usually performed at 16 to 22 weeks. And I would highlight this gestational age because many of the colleagues would refer to us that fetal echo should be done at 26 weeks. And despite our insistence, the patient does not agree for all these fetal echo within the 22 weeks frame or the 24 weeks MTP Act frame. So we need to change our mindset that, it's fetal echo can be performed between the 16 to 22 weeks. Most ideal would be around 20 to 21 weeks. But the sensitivity of the 4-chamber view is about very, very minimal. That is about 5 to 60%. And sensitivity becomes higher by the combining the other outflow tracts. And in the good centers, the sensitivity has been 18 to 90, reported as high as 80 to 96%. So those who do the dedicated scans. And the AVSD is the most common prenatally detected cardiac abnormality, which is associated with the trisomy 21. But it can be easily missed as the AV valve may appear normal even with a good 4-chamber view. Hence, the sensitivity of the diagnostic AVSD is low, 29% in the low risk population. But other more complex and obvious structural defects can be easier to detect. Next slide, please. In renal lesions, they account for about 20% of the all congenital abnormalities. And out of the these lesions, approximately 60% can be detected in the Anomalies scan. Next, please. In the gastrointestinal tract, the commonest defect of herniation are the gastroschisis and exomphalus, and they can be nearly 100% detected in the first trimester scans, and of course in the second trimester scan. Upper gastrointestinal atresia, like the duodenal atresia or the esophageal atresia, can be suspected in the third trimester, like beyond 26-28 weeks. And large bowel and anorectal malformations are rarely diagnosed positively antenatally. And in our units also, we have the maximum cases which we have missed in utero, and later on the child is delivered, and then we got the feedback that there was a large bowel anorectal malformation which needed, even they were the high anorectal malformation, but these cases never had polyhydramnios, there was no gut dilatation. So many a times they are being missed, and probably this needs counseling, that these can be missed, and so that by the time they get back all these surgeries, they are annoyed with the person who has done it. So if we know that these can be missed, there can be hardly any subtle findings also on the on the ultrasound. So probably we can counsel them in a better way. Next slide, please. The cardiac abnormalities detection rate for the AVSD is around 29%. So 1/3 cases only can be picked up. VSD, it is very, very low. It is about 11.5%. The sensitivity is higher for the hypoplastic left heart, around 50 to 55%. And for outflow tract abnormalities, it is about 21.2%. And these are all low risk populations. Next slide, please. So we have a list that whether it can be, so the first trimester, we can 100% identify the anencephaly, the holopresencephaly, the severe hydrocephalus, the gastroschisis, omphalocele, the megacystis, cleft lip palate, cystic hygroma, and arthrogryposis and lethal skeletal dysplasia can be identified if they are severe enough. Whereas in the second trimester, the agenesis of corpus callosum is generally not identified in the first trimester. The microcephaly is usually identified in third trimester on the serial evaluation of the head circumference. Open neural tube defect is easily and more confidently being diagnosed in the open neural in the second trimester. In the first trimester, many of the good radiologists, I find them that by the intracranial translucency, they are able to suspect, but most of them 99% are not confident to give us the direction that whether it is actually an open entity, so that we can go ahead with the termination. So in the practice, I have realized that when they are telling us that there is some abnormal intracranial translucency, then we can add up the alpha fetoprotein. In the current times, because of the first trimester quadruple test, alpha fetoprotein can help us in diagnosing these cases early, because if we are suspecting them early and we are not giving them direction to terminate, then it becomes a mess for the patient. She becomes very anxious, there is lots of stress. So probably adding one clinical test like the first trimester quadruple is available, so that will give them direction whether to terminate. If it is high, then it can. So in the second trimester, the congenital pulmonary airway malformations can be detected by the large echogenic lungs, AVSD, and the renal agenesis. I keep on seeing that unilateral renal agenesis can be missed many a times. And bilateral renal agenesis also has, but there are more chances that the bilateral renal agenesis will not be missed. ARPKD, that is the autosomal recessive polycystic kidney, usually identified in the second trimester. Those who do quality scans, they suspect in the first trimester, and later on reconfirmed in an early anomaly scan around 16 to 17 weeks. Hydronephrosis we mainly detect at the anomaly scan. Megacystis can be picked up even in the first trimester also. Cleft lip palate are usually confidently diagnosed in the second trimester only, and non-lethal skeletal dysplasia like the achondroplasia usually suspected after the 20-week scan. That is, you send them for the growth scan at 28 weeks or 32 weeks, and then you are going to realize that okay, all the long bones are short, and so probably, and the head is large. So we are dealing with the non-lethal skeletal dysplasia, and this is not an uncommon finding. Achondroplasia many a times presents like in the third trimester only. So this may not be evident at the anomaly scan. Next slide, please. The renal abnormalities, the multicystic kidney diseases like polycystic and all, they can be diagnosed, and the detection rate is quite high for the multicystic and kidney diseases. And for hydronephrosis also it is in the tune of 93%, but the PUJ obstruction, it is a little less, that is about 25%. And posterior urethral valve, the severe one can even be diagnosed in the first trimester, and later on in the second trimester, the moderate to mild one can be diagnosed, and the detection rate is pretty high, that is about 60 to 70%. Next, please. In GIT, the gastroschisis and the exomphalus, nearly 100% detection rate, but the esophageal atresia or the tracheoesophageal fistula, many a times we have also missed, even if there was a suspicion of polyhydramnios, but because the stomach bubble was already visible, so despite our all efforts, we could not diagnose the tracheoesophageal fistula. And later on after the birth, when the child had problem, we got to know that this polyhydramnios, the reason for this polyhydramnios, the late onset polyhydramnios in the third trimester, was due to the tracheoesophageal fistula. Duodenal atresia, we get referrals after 26, 28 weeks that there is a double bubble stomach, and 30% of these are associated with the Down syndrome. So mainly they are beyond the anomaly scan, they will be picked up, and the idea is to do the amniocentesis so as to identify, because 1/3 of them will have Down syndrome, but the rest 2/3 have good outcome, so that if there is a node, like out of 5 or 6 cases of duodenal atresia which we did amniocentesis, only one had got Down syndrome, rest all were corrected by surgery postnatally, and one family had recurrent duodenal atresia, but both the children are mentally fine because the amniocentesis was normal. Next slide, please. So among the CNS, I have classified these abnormalities that which can be diagnosed always, where there is a possibility less likely, and which are the unlikely to be diagnosed on the ultrasound as per the system. So like in the central nervous system, the anencephaly, the exencephaly, the acrania, that has to be diagnosed almost 100%. Ventriculomegaly also 100%. Cerebellar hypoplasia, we can suspect, so this can be diagnosed, but most of the cortical malformation, they cannot be picked up in the anomaly scan. In the cardiovascular abnormalities, always the hypoplastic left heart, the Epstein anomaly, the complex cardiac abnormality, the tetralogy of Fallot, they should always be diagnosed. And more likely the AVSD, the rhabdomyoma in the later on scan, they can be diagnosed. But atrial septal defect, the ventricular septal defect, they are less likely to be diagnosed. In the face, the cleft lip and the hard palate, they should be diagnosed always. But ear malformations, eye malformations, they can also be diagnosed and the binder facies. But cleft soft palate, maxillary hypoplasia, mandibular hypoplasia, they are unlikely to be diagnosed as the facial abnormalities. So many cases of Treacher-Collins syndrome, which we have seen as a missed, they were because there were mandibular hypoplasia, maxillary hypoplasia, so they could not be suspected. So if the couple comes to us that we had got all good scans but they missed it, so we can tell them that these are hard to be detected, these facial anomalies. Then in the GIT, the intestinal obstruction and the high anorectal malformation, even the imperforate anus cannot be diagnosed. So next slide, please. And the one ultrasound abnormality or the postnatal abnormality which causes lots of litigation is the limb reduction defect. So this I feel that either 100% should be diagnosed, and the lethal skeletal dysplasia should 100% be diagnosed. Polydactyly, if somebody is very much, meticulous, then probably they can diagnose. But isolated polydactyly, 90% of the cases, I feel that, isolated one single polydactyly is missed. Syndactyly, partial digit amputation defect, that is the last one or two digits, they are difficult to be picked up. And achondroplasia is usually diagnosed in the third trimester only. Then in the kidney malformation, the cystic kidney diseases are easy to be picked up because of the difference in the echogenicity of the kidneys, and the posterior urethral valve, because of the megacystis or the dilated ureters, they can be picked up. And the pelviureteric junction, the horseshoe kidneys, they can also be picked up on the ultrasound. Next slide, please. The unilateral renal agenesis is difficult to be picked up. So the detection rate is, the CNS abnormality is about 76%. Urinary tract is also quite high, 67%. Pulmonary, that is the CPAM and the sequestration, is 50%. Gastrointestinal tract abnormalities is little less, because many of the intestinal obstruction and the esophageal atresia, they are late to be picked up. Cardiac abnormalities also, the sensitivity is the less. Next slide, please. So this is a 2018 paper, and this highlights the effectiveness of the 12 to 13 week scan for the early diagnosis of the fetal congenital abnormality in the cell-free DNA era. Next, please. So here they conclude that a high proportion of the fetal anomalies will be detected at 12 to 13 weeks of the gestation, and the detection rate is usually around 50% in the first trimester. So these days, along with the NT-scan, many of the good radiologists and the fetal medicine specialists, they have started doing the anomaly scan in the first trimester itself. And I keep seeing that the detection rate is quite high. That is about 50 to 60%. Next slide, please. This is our paper which we had published in the performance of the first trimester ultrasound in the detection of the structural abnormality in the Indian women. So many good radiologists and the fetal medicine specialists, they are shifting to the first trimester, because now in the era of the cell-free fetal DNA, the NT-scan, for the just the purpose of the NT measurement is, in addition to that, now we are seeing lots of anomalies being picked up in the first trimester. Next, please. Next, please. So always detectable are the holoprosencephaly, acrania, exencephaly in the first trimester, the body stalk abnormalities like the limb body wall complex, megacystis, limb reduction defects. Next, please. Malti, next, please. So not to miss is the acrania, anencephaly, ectopia cordis, encephalocele, gastrocysis, omphalocele, holoprosencephaly, DORV, limb reduction defects, and megacystis. Next, please. Skeletal dysplasia, lethal skeletal dysplasia, facial clefts, aortic coarctation, dandy walker, arthrogryposis. They may be a late manifestation, but yes, later on in the, they can be beyond anomaly scan, they can be identified. Transposition of the great vessels, spina bifida, and hydrocephalus. Next slide, please. So among the list which can be missed, the commonest is probably, I feel, that is the Down syndrome. And a normal ultrasound, ultrasound can be normal in about 30 to 40% of the cases, because we have seen many cases where everything was perfect, still the baby has Down syndrome, including the dual marker. So we have to counsel, when a normal ultrasound has been done, we can tell them that the accuracy of the ultrasound in detection of the Down syndrome is just 60 to 70%. Next, please. Then, as we discussed, that ultrasound is very good at the internal viscera, like the heart, the stomach, the bladder, but it's not good for the facial abnormalities or the external abnormalities. And this was an IVF conception, and the lady had, the polyhydramnios, and all the stomach was checked, the bladder was checked, and the sugar was checked. They were all good, but the IUD happened at 35 weeks. And the fetus was sent for the fetal autopsy, and we found that there is a significant facial abnormalities. There was a severe retrognathia, absent multiple mandible, hypoplastic maxilla. These all cannot be picked up on the ultrasound. There was a high arch palate, and left ear was absent upper part of the ear. So many of the ear malformations which we are coming across, that they are, because ear is the organ which is posteriorly placed and the position of the fetus. So many of the ear, rather I can say that 90% of the ear malformations are being missed, and it is because of the limitations of the ultrasound. And ear is the first thing which the family would see. So many of them are upset. So if we know that, how to tell them that, because of the position, because then we start thinking that, okay, our colleague have missed, and we also start, indirectly start supporting the statements made by the patient, even if we are not saying anything. But we need to tell them, assure them that, the ultrasound is not very good at the ear malformation. It may be dependent upon the fetal position, your BMI and all. So this, if we know that this can be missed, and of course later on the plastic surgery can be done, so that we can counsel them, because they really get very, very upset because this is the first thing they would see when the child is born. Next slide, please. This fetus had early onset FGR, large head, and the IUD happened, and later on this was identified at RRD. And here the cell-free fetal DNA was already done, and which was normal. So the lesson here was that the cell-free fetal DNA will not pick up the RRD, because this is the doses-based analysis, which most of the NIPT are being done. So this will not be picked up on the RRD will not be picked up. So we have to clinically suspect when there is a severe FGR, early onset, and there is a large head along with the abnormal biochemistry. Probably that will give us a clue for the RRD. RRD has two types of abnormal biochemistry. They may give you a risk of high risk for alpha neural tube defect, or even the other type, that there could be a high risk for the trisomy 18. So both are possible in the cases of the RRD. So along with the ultrasound and the biochemistry, we can have a larger suspicion, greater suspicion for the RRD. Next, please. This, the situs abnormalities, many of the cases which have been referred to us for the in the complex cardiac malformation for the fetal autopsy, and to our biggest surprise, about 30 to 40% of them had situs abnormalities, where the heart was totally on the different side and all other organs were also. And it was in many good center also, I had found this discrepancy, that the situs was written as normal. So because this was a total mirror image, so this can also be missed. And this is a very, very common occurrence these days, because here when everything is on one side, the determination of the laterality is not very easily being done, or not very routinely being done in most of the centers. So this is a very common occurrence to me in the autopsy. And now also in the newborn, in the nursery also, a newborn baby admitted in our nursery with the breathlessness. For first 2-3 days he was being given supportive therapy, and suddenly one day someone realized that there is a situs inversus, and then the workup was done, and then this was a type of the laterality defect, and the mutations were confirmed. And the couple kept on asking me why this was missed. So we need to provide some good answers, that the laterality may be missed when it is totally because this is one area where I feel that lots of expertise and is needed, because we are not paying much attention to the laterality. If they are complex cardiac malformation, it doesn't matter much to us, because anyway the pregnancy is terminated. But in the children, with those who are all good, for them also it will matter, because they are prone to have the recurrent respiratory tract infection, frequent admissions. So we need to identify more carefully the situs abnormalities as well. Next, please. So there are guidelines which has to be followed, and the recent guideline has been given in 2022, and these are the updates for the previous guideline, because it has been realized that despite all those guidelines, still there is much scope to be improved upon. So these guidelines are revisited in the 2022. Next, please. So as per the EuroCat surveillance of the congenital abnormalities, so we should be knowing this slide is important in the practice. If we can just memorize, like anencephaly and similar, like about 90 to 100%, spina bifida about 60 to 70%, TGA is very, very minimal, it is about 1/3 only, 33%. Left heart, hypoplastic left heart is a little higher, 65%. Gastroschisis is about 83%. Bilateral renal agenesis can be easily picked up because of the severe oligohydramnios. Of course, finding out the kidney is difficult, but with the absence of bladder and with the severe oligohydramnios, this can be picked up clinically. So it's not only about the imaging, you have to also think clinically also, that if there is absent bladder and there is a severe oligohydramnios, it has to be bilateral renal agenesis. And little more further, that by the renal artery Doppler they can identify that this is a renal agenesis and needs termination and maybe genetic testing also. Down syndrome, the detection rate is about 60 to 70% despite the best ultrasound. Next slide, please. Next, please. So this, yeah. So to conclude, at least one scan in the mid trimester, and 60 to 70% of the congenital malformations can be identified. Ultrasound is more good at identifying the internal organs. Many external anomalies can be missed, but thankfully, none of them, they are of much consequence, like, only the cosmetic. And because our MTP Act has been modified, so we need to be more, we can, stretch a bit to 20 to 22 weeks. I feel that we need to train more people, and a timely referral to the tertiary center is a must. So we need to push our infrastructure, our talents and the skills.